Welcome. I'm Sherif Nagueh. Will present today on the assessment of hemodynamics by Doppler echocardiography. Before we start, I want you to know that your questions are welcome, and you can send us the questions either by text to DeBakey 37607 or online to polev.com/DeBakey. Now we'll start by talking about pressure and its measurements, and we'll also talk about flow in the subsequent slides. So pressure is defined as force per unit area. And if we use the SI units, not the British metric system, then you're talking about Newton per meter squared or dynes per centimeter squared. And Newton is 10 power 5 dynes. So if we stick with these units, 1 Newton per meter squared is equal to 1 Pascal. Let's look at other expressions for pressure that are more useful. If we're dealing with solids, the first expression is certainly something that we rely on, but let's look at applications as they apply to fluids. So we can replace force as the product of mass and acceleration from Newton's second law, and we can replace mass as the product of density and volume. If you divide volume by area, you end up with the unit of the distance. And so another expression for pressure is density times acceleration times distance. For fluids that are stationary or in motion, but above the center of gravity, the acceleration that we are interested in is the free fall acceleration. Again, if we use the meter per second squared units, G is 9.8 meter per second squared, or 980 centimeters per second squared if we want to convert from meter to centimeter. Many times we talk about pressure in terms of centimeters of water or millimeters of mercury. And so how do we get from this to centimeters of water and to millimeters of mercury? For centimeters of water, and assuming the density of water is 1, which is very close to the real density, you end up with 1 centimeter of water exerting 980 dynes per centimeter squared. If we're interested in mercury, which is more dense, and therefore we would not be interested in a centimeter of mercury, but millimeter of mercury, and you use the density of mercury, that's the expression we get, which makes it clear now that 1 centimeter of water exerts the same pressure that 0.738 millimeters of mercury exert. About flow. Flow is defined in units of volume per time. And if we look at flow through a cylinder, and assuming the flow is filling the whole cylinder, we can say we want to get the volume of that cylinder. And so it is the area of the cylinder, the cross-sectional area of the cylinder multiplied by the velocity. And you can see that this will give you the units of volume per unit time. If it's a circular assumption for the cross-section, that's what we get. If we want to work with diameter as opposed to radius, then it's 0.785 multiplied by the diameter squared multiplied by the velocity. If it is an ellipse, then we want to get the 2 perpendicular diameters of the ellipse, the major and the minor, and that's the expression that we get. Looking at flow in a rigid tube with resemblance, as you will see, but with some differences to elastic tubes. First, let us see what happens. As the flow enters the tube, the flow moves with a high velocity, but then layers of fluid gradually get attached to that inner border of the tube, such that the layer of the fluid in immediate contact with this edge is not moving. And as you go from the outside to the inner core of this tube, you see velocity increasing. The distance over which this parabolic profile is formed is referred to as the entrance length. When we think of motion, we think of forces that help motion and forces that resist this motion. For fluids, viscosity is the frictional force. Blood behaves as a Newtonian fluid, and what that means is that there is a direct relation between the shear tension, which has the same units as pressure, force per area, and velocity gradient. The velocity gradient we are talking about here is a spatial gradient. So there is the shear tension directly related to the spatial gradient of the velocity, with the constant being the units of being the viscosity. If we are interested in viscosity, then we rearrange this expression, and you would see now that you have the tension, which we said is force per area, or would have the units of the Pascal, the same units as the pressure. And then dividing the distance by the velocity, you end up with second in the numerator. So the units of viscosity are the Pascal seconds. Looking at a approach that relates pressure differences and flows. Flow happens from point 1 to point 2 because there is a pressure gradient whereby pressure at point 1 is higher than pressure at point 2. The distance between these 2 points is given by L. And if we take a cross-sectional area and we say this is a circle, then we have a maximum radius from the center of the tube to the edge of the tube. And then if we look at concentric layers of fluid moving, these would be layers that move with different velocities, such that the velocity is maximum at the center and 0 at the edge. And in between, you will have a velocity value that exceeds the 0 but is less than the maximum. You're looking at variable layers with variable radii. The smallest is closer in, and the largest, or the utmost largest, is the A. At equilibrium, the pressure force and the friction force are in balance, and we can look at this expression. We said in terms of forces, pressure is force per unit area. So if you multiply the pressure difference by the cross-sectional area, and assuming it's a circle, that's the expression you get. If we look at the frictional force that is trying to stop this motion, it is related to the shear tension. And here it's the surface area of the cylinder. So it's the circumference of that circle multiplied by the length of the cylinder. Now we want to look at these signs. And we see that because the viscosity is opposing the pressure force, it ends up with a negative sign. And we rearrange this expression. You notice that the pi would cancel and the radius becomes 1 radius only, not r squared. And we know that the viscosity is also given by the spatial gradient multiplied. The shear tension is also given by the product of viscosity and the spatial gradient of the velocity. We end up rearranging here, and then we do an integration, and we integrate over the limits between the velocity being maximum at the center and 0 at the edge, and a radius being the narrowest radius of R and the maximum at the edge of A. And at the center, you are left with a velocity maximum that is directly related to the pressure gradient, inversely related to the length of that tube, and directly related to the square of the radius. Many times, what we end up using in the calculation is the mean velocity and not the maximum velocity. And so we go back to this expression and we say that the flow is given by the cross-sectional area multiplied by the mean velocity. We assume the mean is, it can be shown that the mean in general is half that maximum velocity. And you see this expression that on the third line from the bottom, where flow is directly related to the 4th power of the radius, the pressure gradient, but inversely related to the length and to the viscosity. If one is speaking in terms of resistance, then resistance is directly related to the length of the tube and the viscosity, but inversely related to the 4th power of the radius. So that's Poiseuille's equation. How does it apply in the human body, so to speak? One of the assumptions is that you see in this expression is that the viscosity is constant and does not change. And that assumption holds till you start looking at very small blood vessels, less than 0.5 millimeters or 1 millimeter, because here some cells would enter and some others would not. And that changes the viscosity of the blood. These very small vessels are usually not examined by Doppler. The second assumption that we talked about here is there is laminar flow, and that is valid assumption except for a very short distance in the pulmonary artery and the aorta. All of the calculations that you saw on the previous slides were assuming a circular cross-section. And so if you're looking at tapering vessels, there would be a different approach needed to come up with the relations between flow and pressure gradient and the geometry of the tube. The largest error comes from the assumption that this is an inelastic tube. As you know, the human vessels are not inelastic tubes, and that results in an error of at least 10%. Last is the assumption that the flow is steady. It doesn't change. As you know, again, flow is pulsatile with a varying velocity profile. However, one can look at the temporal mean, and relations using the temporal mean can still give us useful information. Many times when you read about Reynolds number. This is a dimensionless number, meaning it has no units, and it's a balance between inertial forces and viscous forces. When the value of this number is less than 2000, flow is generally laminar. When it exceeds 3500, it is turbulent flow. In between, one refers to the flow as transitional flow. Let's look at why the Reynolds number is a dimensionless number. In the numerator of the Reynolds number and as determinants of inertial forces, we see the product of density, velocity, and the diameter of the vessel. In the denominator, it's viscosity. Remember that the units of viscosity are Pascal second. So now let's see if the numerator has the same units as the viscosity. We can replace density as mass divided by volume, velocity times diameter. We can replace mass as force divided by acceleration from Newton's second law. And now if you look at this expression, you have the force, you have the velocity in the numerator. And for that numerator expression, velocity is also in the acceleration, because acceleration is velocity divided by time. And so the velocity cancels. You have a distance in the numerator and you have a volume in the denominator. So when you reduce these, it becomes area. And so you now have force divided by area multiplied by time. That is Pascal second, the same units as those of viscosity. We already talked about flow and how it is quantified, either assuming a circular cross-section or an elliptical cross-section. When we look at errors that can come in the calculation of flow, they can come either because we make errors in the velocity measurements, or we make errors in the calculation or the measurements of area. As you expect, diameter measurements would introduce errors. If we assume it's a circle or an ellipse and it is neither, that introduces errors. That's why direct measurements of these areas, if the images are of suitable quality, can avoid some of the geometric assumption limitations. The issue of phasic flow and instantaneous changes in area should not be ignored, because the area is varying over the period when flow is happening. Also, an area is not fixed. It can change with absolute flow. That was shown in vitro. That is the principle behind looking, for example, at aortic valve area as you increase flow by administering an inotropic drug. What is the appropriate site for measurement of the diameter? Ideally, you want to measure the diameter at the same location that you measure the velocity, so that you can combine the two measurements. Measuring them at different locations can be a problem. And as we talked for some time now, if possible, direct measurement of area can be better than measurement of diameter. However, if this area is not well visualized and it is used for the calculation of flow, then that would introduce an error also. Many times a question comes, what is the error in diameter? How does it translate to an error in the area? This slide shows you the bottom line on that last line here. This is simple algebra. It shows that the error in area is really twice the error in the diameter measurement. It's not squared. Looking at errors in velocity measurements, the first assumption that we put is we assume that the velocity is the same across the profile of flow, and that may not hold. The second assumption is when you have a spectral profile and you have red blood cells moving with different velocities, do you take the highest velocity? Do you take the mean velocity? The velocity that we take actually is the modal velocity. This is the velocity with which most cells are moving. The third assumption when we do the calculation that can be problematic is the velocity that we are measuring in a given view is a representative of the 3D vector. And as you can imagine, this may not be the case. The strength of the signal, if it is faint and the contour is incomplete or not clear, would result in errors of measurement. Many times, in fact, the usual is we do not measure area and velocity at the same time. And that is problematic in individuals who say have arrhythmias, be it atrial fibrillation, frequent ectopic beats. And then the assumption of continuity. The assumption of continuity is simply stated that the flow at one point is the same as flow in another point. For example, if I am measuring flow just below the aortic arch and I am making the assumption that they are equal, this is an invalid assumption, because in between these 2 points, there is coronary blood flow. And so the flow at the level of the outflow tract would exceed flow higher up in the aorta by that volume. We can calculate, and we do report, cardiac output and stroke volume. Stroke volume is given as the product of cross-sectional area and the velocity time integral. If we assume it's a circle, then that's the expression we use to get the area of a circle. Or if I do not want to deal with radius, it's 0.785 multiplied by the square of the diameter. The units of the time velocity integral are units of distance, as you see here on that line. How do we get the time velocity integral? In the older days, one would assume it's a triangle, and then you get the area of the triangle as half base times height. We do not need to go to that assumption. Nowadays, you can directly obtain that on the ultrasound systems or offline on your imaging station. Finally, combining stroke volume with heart rate leads to the cardiac output. And if you know the body size, body surface area, then the cardiac index. Doppler echocardiography was successfully used to look at changes in stroke volume and cardiac output in different situations. For example, drug therapy in patients with heart failure reduced ejection fraction and what happens to their cardiac output when you give them a positive inotropic drug. What's the effect of different pacing modes, different pacing intervals on the stroke volume and cardiac output, and how to adjust these so you get the maximum stroke volume for a given patient. What are the changes that happen in cardiac output with physiologic situations? How about cardiac output for fetuses and neonates? And then looking at flows with exercise Doppler. While the principles hold with respect to exercise Doppler, having higher quality data can be more challenging in this setting. Aside from these applications, there are other applications that we rely on flow measurements. For example, calculating shunts, or the ratio of flow across the pulmonary circulation to the flow across the systemic circulation. Determining regurgitant volumes. How do you determine aortic regurgitation? It's the difference between the stroke volume and mitral inflow. Mitral regurgitation, difference between stroke volume and aortic outflow. And pulmonic regurgitant volume is the difference between flow through the pulmonic valve or the right ventricular outflow tract and aortic flow. We use it a lot in the valve area calculations and the continuity principle. And if you have a good feel of stroke volume, it can help you, if you know the size of the ventricle, to get an estimation of ejection fraction. Let's look at measurements that we acquire routinely. We get the left ventricular outflow tract diameter. You want to zoom, so you minimize the error in the measurement. And then you get the time velocity integral using that modal velocity. And if you combine the two together with one of the circular cross-section equations, you end up with stroke volume. We can do the same for the RV outflow tract. The RV outflow tract is more challenging in measuring its outer border, as you see in this slide. And in the older days, when they were looking at validating these measurements, if you were to use an angiogram that gets you the RV outflow tract along with the pulmonic valve and the rest of the pulmonary artery and use that to acquire the diameter, you end up with very comparable values to the real flow. One trick one can do is to put color here so it helps you identify the outer edge. And then we combine that with the time velocity integral to quantify the flow across the right ventricular outflow tract. For mitral inflow, we use the inflow at the level of the mitral annulus, and we combine that with the mitral valve area. In routine acquisition of flows across the mitral valve, we have to acquire the signal at the level of the annulus and at the level of the tips. The tips is used for indices of diastolic function, but not for quantifying flow. Quantification of flow comes from the signals acquired at the level of the mitral annulus. This cartoon illustrates how you can look at determining the mitral regurgitant volume. If you know the difference between the left ventricular end diastolic volume and end systolic volume, this is the stroke volume. That stroke volume is really going in two directions, through the aortic valve into the root of the aorta and through the mitral valve into the left atrium. And so the mitral regurgitant volume is the difference between the stroke volume and the aortic flow. Let's look at an application in a real case. So that's a patient with a flail posterior leaflet, segment of the posterior leaflet, who has bicolor Doppler a sizable amount of regurgitation. We want to quantify this. So first we will acquire the mitral annulus. We will acquire the mitral inflow at the level of the annulus. We will acquire the left ventricular outflow tract diameter with the zoom. And we will acquire the flow through the left ventricular outflow tract from an apical lung axis view. And now we start plugging the numbers. So there is the annulus measurement. There is the time velocity integral across the mitral annulus. There is the LVOT diameter, and there is the LVOT time velocity integral. The first line shows you the flow across the mitral valve. This is a circular assumption. The second one shows you the flow through the left ventricular outflow tract, and the difference between them is the regurgitant volume. This could be expressed in relation to the total stroke volume. In this case, it's 113, and you end up with a regurgitant fraction of 63%. We can apply the same principle for aortic regurgitation. This is a patient with isolated aortic regurgitation, a dilated root. There is the aortic regurg bicolor. We get the aortic flow, and it's 82 milliliters. Again, the same principles that we applied, circular cross-section with the time velocity integral of 26. We get the RVOT flow, which is 54. Then you know the regurgitant volume, and you can determine the regurgitant fraction as you see on the slide. To get good numbers, you need good quality signals. Shifting gears from flow to energy, pressure, and flow relations. Energy is defined as the capacity to do work, and work can be looked at as the product of force and distance. And we just said that force per unit area is pressure, or force can be replaced as the product of pressure and area. Area multiplied by distance gets you volume. And so now you see that the product of pressure and volume will have the units of work. Let's look at another expression of work. We can replace force as the product of mass and acceleration multiplied by distance. And if we look at changes in this expression and we replace mass as the product of density and volume, and we have here the acceleration as velocity over time and distance as the product of velocity and time, canceling time, you end up with the velocity squared. And now you have an expression for kinetic energy. The product of mass and free fall acceleration and height will give you the potential energy term. So the sum of these, the pressure volume product, the kinetic and potential energy, reflect the energy that is in a system. If we compare flows at these 2 points, point 1 and point 2 has a smaller cross-section of area. And because flow through point 1 is equal to flow through point 2, it follows that the velocity at point 2 is much higher than point 1, and the kinetic energy at point 2, which is directly related to that velocity squared, is higher than that at point 1. This first line that you see here is the continuity equation that we rely on to determine belt areas, for example, aortic belt area. Let's look at the full Bernoulli equation. It looks at obtaining total energy. We talked about pressure, volume product. This is the term that looks at kinetic energy. This is the term that looks at potential energy. If we express energy per unit volume, this term reduces to that second line. The energy levels at these 2 points is the same. Energy is conserved. That's the assumption behind the Bernoulli equation. And so we can plug these values on both sides. Because points 1 and 2 are at the same level of height from the center of gravity, the inertial term can be ignored, and we therefore can rearrange this expression to see that the pressure gradient is equal to half multiplied by the density multiplied by V2 squared minus V1 squared. Because V2, the velocity where the area is narrower, is so much higher than V1, its square is also so much higher than the square of the velocity at point 1. And so V1 squared can be dropped from this expression. And that's the term that we get. Most of us understand this, but the question comes, how does that translate to the 4V squared? The way it translates to the 4V squared are changes in units measurement. So first we change the velocity from meter per second to centimeter per second, and that results, because the velocity is squared, in a multiplication by 10 power 4. And then we are interested in expressing the relation in terms of millimeters mercury against velocity. And when you remember that the pressure exerted by 1 millimeter mercury depends on its density and 980, and you rearrange this to obtain it in terms of millimeters of mercury, you see that the pressure gradient is equal to 3.97 multiplied by the velocity squared. There are limitations to the modified Bernoulli equation. This is the full equation. And if you take a closer look, you can see that there is a differential of velocity with time. At the maximum velocity, which is the time when we are plugging, or the values that we're plugging for V2 and V1, the differential is 0, and that can be ignored, and that's the term that you are left with. However, at valve opening and closure, the inertial term cannot be ignored if you want to be more comprehensive. Another important point to bring up when you look at the full equation is this V1 if it exceeds or is at least 1.5 meters per second, cannot be ignored, and it would result in overestimation of the pressure gradient if you ignore it. And so it is important when you apply the modified Bernoulli equation to look at this term and see if it is reasonable to ignore it or not. Usually this becomes an issue when you're looking at sequential stenosis. Now let's look at clinical applications for pressure gradients. Pulmonary artery pressures, gradients across stenotic valves, prosthetic valves, intracavitary gradients, looking at a systolic index of left ventricular and right ventricular function and making use of the mitral regurg and tricuspid regurg jets respectively, and then estimating end diastolic pressure of the left ventricle using the aortic regurgitation jet and left atrial pressure using mitral regurgitation jet. We do this daily in the lab, and the assumption that we apply is indeed the Bernoulli equation. And here the difference in pressure gradient between the right ventricle and the right atrium is given by 4b squared, where this tricuspid regurg velocity is in meter per second. And as a result, if you get this pressure difference and you add to it the right atrial pressure, you have the right ventricular systolic pressure. In the absence of pulmonic stenosis, the RV systolic pressure and the pulmonary artery systolic pressure are equal. We can apply it also to estimate pulmonary artery diastolic pressure. The interest here is in the end diastolic velocity. And so we use that end diastolic velocity, square it, multiply it by 4, and then add the RV end diastolic pressure. In many situations, the RV end diastolic pressure and the right atrial pressure are close to one another. And so if you have a non-invasive estimate of right atrial pressure, you can plug it into this expression, and now you have pulmonary artery diastolic pressure. An example of an aortic stenosis jet obtained from the suprasternal notch that you can look at, trace, and then use in the continuity equation to get the valve area, or use the 4b squared to get the peak gradient of the aortic stenosis jet. This is an example of a patient with severe mitral stenosis, and you have the flow across the mitral valve during diastole. You can trace this signal and you can get the peak gradient and the mean gradient as well across the stenotic mitral valve. That's an example from a patient who has atrial fibrillation, showing you a comparison between the left atrial and left ventricular pressure gradients and the gradients obtained by Doppler across the prosthetic mitral valve. You can appreciate that if we just look at the pressure values by catheters, not at the Doppler for now, there is a lot of beat-to-beat variation because of varying RR intervals due to the atrial fibrillation. A closer look at the comparison between Doppler gradients and gradients by catheter, you see that they match one another really well on a beat-by-beat basis. This holds very true for stenotic valves, for prosthetic valves, provided you have good alignment and no angulation between the ultrasound beam and the direction of flow. This is dynamic intracavitary gradient with a peak velocity at 6, and you can apply the modified Bernoulli equation here to convert that velocity of 6 meters per second to the gradient that is present in this ventricle. We rely on that a lot, for example, in patients with hypertrophic obstructive cardiomyopathy. Let me take you through an example now of how to apply these principles and determine the rate of pressure change during systole, the dp/dt. The higher the value, the better the systolic performance. It's not the gold standard of pure LV systolic contractility, so to speak, but still is a useful index. So we look at the pressure gradients at 2 time points. The first one corresponding to a velocity of 1 meter per second, the second one corresponding to a velocity of 3 meters per second. If you convert that with a modified Bernoulli equation, you end up with a 4 millimeter mercury at the first time point and 36 for the second time point. So now in the numerator, you have a 32. And for the denominator, we look at the time interval between these 2 points, which you measure from the continuous wave Doppler signal of the mitral regurgitation. In this case, is 67 milliseconds. You convert it to seconds, so 0.067, and you end up with that dp/dt, which is markedly reduced in this ventricle with systolic dysfunction. As opposed to taking a quantitative approach, you can also use this Doppler signals qualitatively. For example, you can look at dp/dt from the tricuspid regurgitation jet, and you can compare these two ventricles. Here it is slower rise, here it is faster rise. So the systolic properties here are better. You can also look at the descent and get a feel for now negative dp/dt. And again, you see that the negative dp/dt here is worse than what you see in the better performing ventricle. Talking about aortic regurgitation and estimation of left ventricular end diastolic pressure. There are problems in general for this approach. It is not the best method or the most reliable to estimate end diastolic pressure, but it is still a value for you to see how data may be used and apply the modified Bernoulli equation. So here, if we look at the end diastolic velocity for the aortic regurgitation jet, and we know the diastolic blood pressure, we can say that the difference between diastolic blood pressure and end diastolic pressure is given by 4b squared. And if you rearrange this expression and knowing the diastolic being 70, you can estimate the end diastolic pressure. So with that, I will conclude the presentation, and thank you very much. Ready to entertain questions. I do not see questions.
Dr. Nagueh, I had a quick question. It's a little bit less about Doppler per se, but when you're doing the mitral inflow calculation so as to maybe estimate, aortic regurgitation or what have you, are there any the assumptions when you're basically drawing the line to estimate the area of the mitral valve? Because it's, it's an ellipsoid structure. Is there a particular view that you like to do that linear measurement in for the diameter? Are there, and do we just do an assumption as if it's a circle?
So theoretically, it makes more sense to deal with it as an ellipse rather than as a circle, in which case you want the 4 and the 2 chamber views. Having said that, there are invasive validation studies which looked at this approach versus the approach of assuming it's a circle and just relying on the apical 4-chamber views and using the stroke volume as by right heart cath as the gold standard. The simple circular assumption was just as accurate as the ellipsoidal assumption. For that reason, the circular assumption is a reasonable one to use.
Thank you.
Okay. With that, I thank you all for joining us today, and tune in next week for another presentation on the Multi-Modality Imaging Conference. Thank you all.